Hello. So welcome to our updated version of our YouTube channel. As ever, we're trying to reach new heights on my mission to find answers, find the truth. In this, we're going to be interviewing Dr. William Hang, Bill Hang, who's an orthodontist I've known for many, many years. So if we could introduce Bill. Bill, hello, sir.
Hello, nice to see you, Mike.
We want to talk about Bill. I really, you've kind of almost been a father figure to me over my years in orthodontics. And I really want to discuss the beginning of this whole airway thing, let's call it, within orthodontics. Because you, as far as I'm aware, were the first person talking about this. And
Right.
I just thought it would be really good to hear it from the man that started the whole thing.
Okay.
So, Bill, what I'm interested in is basically a little bit of your story, how you got into this, into orthodontics, how you then got into this area.
Okay, well, I decided to become a dentist when I was 15, became an orthodontist, just because it seemed logical for me to do that. And I practiced traditional orthodontics for probably 5 or 6 years. I actually taught orthodontics for a year before I went into practice. And I did everything that I was taught to do. I took out teeth, I retracted, brought everything back, and I made straight teeth. But it was in the very early 1980s when I actually decided that I couldn't continue to do this because the faces were not looking good. And there was a general dentist who taught general dentists to do orthodontics in the United States who was alleging that orthodontists were wrecking faces and causing TMJ problems. And so when I heard that, back in the late 70s, I was not happy because I thought he's attacking me and what I was taught to do. But I was too young and naive at the time. As the years went by, I saw cases of my own where the faces didn't look as good. And I began to think this man must have something to it. And I began to explore more and more and more, and then decided that really he did. And I then started a program of continuing education because I decided if I was going to practice, I had to practice in a very different way. I couldn't continue to do what I'd been taught to do because literally it made no sense whatsoever. And I began to believe that what this gentleman, whose name is John Witzig, what he was saying was absolutely true.
And then from there?
From there, I did a lot of continuing education, got on airplanes taking courses here and there. And there were people who were saying, okay, you don't take out teeth, and this is how you straighten the teeth. And that I changed. I was living in a small town in Vermont where, what you do gets home before you get home. Everyone knows. And if you're going to do something new, if it works out, that's great. If it doesn't work out, then you might as well pack your bags and leave town because you're not going to be successful. Things were successful, and I began to, I got better looking faces. But it wasn't until I met your father and ultimately you in the year of 1990 when things really changed for me, because your dad put together the only philosophy of why jaws and faces don't grow well that made any sense. There'd never been anything like that. We were all told that it was a genetically determined thing, but he clearly showed that it was an environmentally determined thing.
Yeah.
The pictures you see here on the screen are perfect because shows a boy who's in his early teens, and there he is in college, and he had 4 teeth taken out in conventional orthodontics, and that's what happened to his face. Anyone who can see that is not okay. The very next slide will show yet another one. If you want to move to the next slide, Mike. Here's a boy that more recently I saw and have tried to help. There he is at age 12. By the time he got to see me, he was in his early 20s over on the right-hand side. And he is actually working in a place where his fellow employees called him the old man. And you can pretty much understand why they might do that. He has hardly any face left. His entire lower face is sunken in, and it's really due to removal of teeth. So this confirmed, all this kind of thing confirmed that I was on the right track. I couldn't continue to do that anymore. And I just had to do something different. And meeting your dad gave me a different way. It helped me understand that indeed both jaws are recessed and that you needed to move both jaws forward. And I began to do that starting in 1990. And then in October of that year, I came to London, and that's when I met you for the first time.
And I must have been quite young at the time.
Yeah. And this is a patient where my realization that airway mattered came from this patient. She was 35 years old, had horrible pain pattern, and I had her an appliance to bring her jaw forward, which made her feel really great. She felt better than she had really in years. But the appliance broke, and what happened, she didn't get into the office for a couple of weeks, and she came in, she was distraught. And she said to me, Dr. Hang, when I came to see you, I was suicidal. I never told you that. But I felt great when I had the appliance in. And then when it broke, I felt like I did when I came to see you, like I was going to drown or choke to death. Those were her exact words. And luckily, that resonated with me. And I thought, well, what does that mean? And if you go to the next slide, you can see, I think there should be a picture there of her airway. Yes, you can see the airway at the base of her tongue, and it's real small. Well, I had no idea what size that was supposed to be. And I called an oral surgeon that I work with, and he said, that should be 10 or 11 millimeters. And it's really 2 or 3. And ever since that time, about early 91 or 92, every time I look at a lateral head x-ray, that's the first thing I look at is the size of the airway. That literally changed my entire life and focus. Everything from that point on began focused, and everything I looked at through that lens of what does this do to the airway? And it's
your comment there that patient says something, and
yes,
that's a nugget of gold, and then that
yes,
starts you out on the journey. I mean, that's half the things that I've worked out in life is from exactly that thing. When someone says something that starts you thinking, you do a bit of lateral thinking and come to some decisions.
There was a practice consultant in the United States that I met back in those days, and he said, what you need to do is to take your white coat off, sit down and shut up and listen to the patient. They'll tell you what's wrong. You just have to be smart enough to know what they're saying. And that's what happened for me. I heard those words and it resonated, and literally everything from that point in my life changed. One thing led to another. If you can go to the next slide, it'll explain it even more. This then was this is a patient that I actually treated with orthotropics. On the left side, you can see pre-treatment, on the right, post-orthotropics. And you can see that this girl had a monstrous overjet, and she'd been told she needed to have teeth taken out and wear a headgear, which would have retracted her back more. Yes. We did what your dad taught me to do, which was to advance the upper teeth, even when you have an overjet in a class 2. We did that exact same thing, developed her lower jaw forward massively. And in the picture there, you can see we have a green line starting at the cervical vertebrae to where her chin is on the left. And then on the right, you can see the green line plus that additional forward movement we gained with the orthotropics. But more than that, just look at the size of her airway that is improved. It's massive, massive improvement here. Yes. And that was the year 2000 when I saw that on this. So the next thing we did, and you can bring up the next slide, is we did a study, and it was published in 2007 in the Journal of Craniomandibular Practice, and this took consecutive cases that I treated orthotropically. And bring up the next slide, Mike, and you'll see the data here. We got a 31% improvement at the dorsum of the palate, 23% at the angle of the mandible, and clear down around the epiglottis region, we had 9%. And these I've never seen another article published in all the referee literature about improving the airway in any orthodontic patient, showing x-rays like this. Yeah. The interesting thing, go ahead, Mike.
I was going to say, that's an airway to die for, not an airway to die from.
Exactly. It's absolutely correct. Once I saw this, I got completely excited about orthotropics, which I already was, but I thought this is really something very dramatic because that nobody else can show this. And the very next slide really puts it in perspective. Put that up. John Remmers is a Harvard trained sleep specialist, and he said that it's all if the jaws were forward in the face, we would not have sleep apnea. Uh, if our jaws were forward like our ancestors, we wouldn't have sleep apnea. So that really resonated with me. I thought, boy, I'm on the right track here, because prior to this, I'd started reopening extraction spaces and stuff, and I saw the improvements. But now I thought, this is so interesting to me and so impactful on the overall health. And I began learning more and more over the years. And it basically completely took over my life, and my life has been literally obsessed with this and how it impacts the patients and their longevity, their health span, and everything.
I mean, sleep disturbed breathing is just toxic for people. I think it just affects about every single health system, from depression to libido, and it's really pernicious for any healthy individual.
It's as another person said, it's the most common chronic disease in all industrialized countries, and it's correlated to literally every chronic disease there is. The ones you mentioned, and just literally every. There's not a chronic disease that's not associated with it. The next part here is really interesting here, because this is a young boy, and I love this little case because the question is, how do you now view the relationship between orthodontics and airway issues? The best way to answer that is to show this case. A boy who has Pierre-Robin sequence, which is an uncommon but very devastating syndrome, sleep apnea and failure to thrive, which failure to thrive means that you're not getting human growth hormone secreted, which, of course, someone who has sleep apnea, they're not getting their necessary REM sleep. So, of course, they're not getting human growth hormone. So show the next slide here. And this is a boy from Chicago that flew to Los Angeles for me to treat him. And you can see how we opened up his airway in the anterior-posterior plane of space by developing the upper jaw forward and then the lower jaw forward. Show the next slide.
Bill, could you put that slide on big again? I think what I really want to highlight to so many people I talk to on the internet and I talk to generally is that we talk about expansion sagittally, transversely. Everyone understands you widen with expansion, but what you're doing here is you're getting sagittal expansion. That front-back expansion.
Exactly. And it's 2017. After listening to people talk about expansion all the time, and that is indeed the knee-jerk reaction of the orthodontic profession, is to expand laterally. But there's a section here I'll show you later. You cannot expand your way out of an anterior-posterior problem.
Yeah.
If you're going to be successful, you must do what your dad said. You must take the upper jaw forward. You must bring the lower jaw forward. Now you can see in the anterior-posterior plane of space in this same boy.
Bill, anterior-posterior for everyone is the front-back direction.
Front to back, yes. In the front-to-back plane of space, how his airway has opened up. And the next slide will show Stephen Sheldon from Chicago, who is head of Lurie Children's Hospital Pediatric Sleep Clinic. And the very next slide after that shows from his book, this very patient published with that x-ray, his sleep apnea was completely cured by doing the orthotropics. And when that happened in the early 2000s, I just went ballistic. I thought, this is crazy. This is amazing. No one else is doing this. We gotta get everyone else involved. So show the next slide, just that next few slides here, Mike, because someone would say, well, is it long-term? Is this long-term? Well, here's an email that I got from his mother. And that little boy is now, well, actually, this is about 3 or 4 years ago, I guess. But he's in his late teens. He's been in college now. And she says he's doing well. And you can show the next two pictures, show that show the little boy. There he is, a tennis player, and there he is with his sisters. He's totally fine, and his sleep apnea was completely eliminated with just by doing orthotropics. I show some other cases here just to show the importance of it all. And here's a man who is a PhD biologist, and he has sleep apnea, but he has to undergo jaw surgery to surgically bring both jaws forward in order to save his life. And what we just did for that little boy essentially did it without any surgery. And wouldn't it be better to do that than to let people get like this and then have to undergo?
It's a very important point. What I've noticed is when I see people doing maxillomandible surgery, bimaxillary surgery, both jaw surgery.
Yes.
Really, they're emulating the objective of orthotropics.
Exactly. Yeah, for years I've said that orthotropics is basically surgery without a scalpel. It's doing what a surgeon would do, but in a very, non-threatening, way. And why would you want to do that? It makes total sense to do that and not allow somebody to get down into this gentleman was in his mid-60s when he had this done. And many people would have died by that time because sleep apnea carries with it a 20% reduction in life expectancy. So what you're really trying to do here is save lives. This gentleman, by the way, that's what his airway looks like after the surgery. And to be honest with you, most surgical results that are being done and reported are not even close to this. So the point is, you can still have jaw surgery to bring both jaws forward and still not end up that well off.
Bill, what I've observed in conversation with people is so many surgeons are using the cephalometric standard norm data taken from x-rays in the middle of the 1900s, which you've got a disease that started 10,000 years ago. It's gently progressed and got worse. Is accelerating in the last 100 years. And people are using data from right at the end of the curve. And I'm thinking, why can't we look back in time, look back at the better craniofacial structure of our forefathers and ancient ancestors?
Absolutely. But what's really crazy is to realize that orthodontists back in the early 1900s were actually treating these kinds of problems, and they were talking about mental retardation and health as the reason to treat. And they were actually treating kids in the primary dentition, which I, of course, teach in my mentorship now. But that went away completely and just came into, okay, you're going to get your teeth straightened when they're all in, and that's what happens. And I politely call that just rearranging the deck chairs in the Titanic because the faces are already too far down and back. It's so silly.
My phrase, but Bill, I use that phrase and quote you often.
Yeah. And here's another one. Here's a gentleman who had 4 bicuspids taken out. His face is caved in and he's got a beard on there on the left-hand side just to cover it all up. And he also goes through MMA surgery. I just had to show that. And then the next slide will show his airway improving rather dramatically. Again, you can see it. But the problem here is, that's a great result surgically. But most of the results which are being published are not even close to this because the cases are not set up properly orthodontically and the surgery is not done the way I would want it to be done. Point is, the answer to this whole question is the airway and the face are intimately related, and one depends on the other. I love to quote a lab technician that I've known for many years who said clearly, this was like 25 years ago when I met him. He said, "Yeah, John Mew makes the best looking faces in the world," and I absolutely believe that. And the fact of the matter is, if you're making that good looking face, then it is also a face that is functioning well because that face is forward, the upper jaw is forward, the lower jaw is forward, and the airway is open. Yeah, and that's what really we ought to be doing.
I think this facial attractiveness is a double-edged sword. And the fact that I think healthy, well-structured faces also look good is, some people accuse me of just making pretty faces. But I often say one of my comments is, your face is the CV of your health. It's an outward
Yeah,
display that you managed to grow healthily. There's your CV out in front of you. You're displaying you're healthy.
absolutely. And I came up with the title of lectures years and years ago, probably 15 years ago. I said, dentistry is literally at the center of healthcare because of this very issue. And based on what we do or do wrong, in my opinion, we are going to determine how long someone may well live. And those of us who went into dentistry, particularly myself, I didn't go into dentistry to save lives. I was going to fix teeth. And here, the last 30 years of my career, literally, I was involved with saving lives. And it's far more gratifying. But I think dentistry literally has a responsibility to be at the center of healthcare. And you've got the attention of the world now, Mike, which is great. And you can help them all know about this. And because the mothers, I call them the mama bears of the world, they're going to change the world.
Yeah.
And once they see that things can be done, they want to have it done.
Well, I've watched my father fighting a losing battle against the orthodontic community to just get meaningful engagement. I mean, I meet so many people who would diss my father, and I say, well, what's he actually thinking? And they don't know. And then they say, well, he's been proved wrong. And I say, well, he's never had any
Oh,
meaningful engagement ever. People just run away.
exactly.
So I felt that the best thing to do is go around the community, go straight to the public, because as you said, this is what they want. And
No.
they will demand this once they know.
Absolutely. They'll move mountains. I mean, Mike, I had people coming from more than 30 states in my practice and several foreign countries. Mothers would move mountains to have something done right for their kids. And the very next part of our conversation here really gets into the mothers that are the most motivated, and that's this extraction-retraction regret syndrome. Now, I'm sitting here in Vermont right now, where in September of 1989, a woman literally forced me to try to reopen her extraction spaces where she'd had teeth taken out. And I didn't know it could be done, but I tried. I was successful. I got rid of her pain pattern, which she'd had for basically ever since her orthodontics, and she was 27 at the time. And so I kept on doing this. I did it in my own mouth. I did it for a lot of other people. And about 15 years ago, we came up with this term extraction-retraction regret syndrome, which, if you put the slide up, I define as a constellation of aesthetic, functional, emotion, signs, and symptoms caused by tongue space airway reduction from orthodontic retraction, all of which are preventable. Now, this is not to say that everyone who's going to have teeth taken out or have headgears and any form of retraction, much of orthodontics does retract whether they want to or not. The face ends up back. It's not to say that everyone's going to have the problem. But I want to tell you, there are truckloads of these people, boatloads, plane loads. There are millions of people worldwide who suffer. And, if it's you, what does it matter? It only happens in a certain percentage. If you're the one who's suffering, you need and want a solution. So the point here is we need to stop the insanity of this kind of thing. And so now go to the next slide. And you can see, for instance, here's a woman who I actually treated. She'd had the 4 teeth taken out when she came to me. That's her profile on the left, all dished in. Once we opened her 4 spaces back, look at where her teeth are and her lips are. She doesn't look so old anymore.
Yeah.
The next slide is going to show you the very first person that I ever did this for, who had upper lateral incisor teeth removed. Notice on the left, she's 27 and she had pencil thin lips there. When I finished her on the right, you can see much fuller lips, and more than that, her headache pattern, which she'd suffered with since the end of her orthodontics, went away completely and stayed away. You can see her in profile in the next picture too. I like to then go to the refereed literature, and so the next slide will show that. My question is, can retraction cause the growth of the lower face to change? So put up the next slide, and we'll talk about that very issue. This is out of the refereed literature, disguised so you can't really see it, but here's a person with missing lateral incisors, and those are baby teeth there. Now, go to the next slide, and you're going to see uh, what happened here. This boy had lateral expansion from age 8 to 12, and his upper incisor teeth came down and forward, and his lower jaw came forward like crazy. If you see the normal downward and forward growth there from the chin, that's massive growth that orthodontists learn happens with normal growth. Now, go to the next slide, if you would, and you're going to see what was done. He had like 4 millimeter spaces, which all you needed to do was open some space up and put implants in. But no, the knee-jerk reaction is to save the child from implants. So they say they're going to bring the back teeth forward, which is ridiculous because they're always going to retract the front teeth with the mechanics. So now show the next slide, and you can see exactly what happened. The lower jaw, which had been growing forward by leaps and bounds, now that they closed the spaces, it didn't grow at all. And my experience is that this happens all the time. Now, you can show the next slide. So what I like to do here is then take something out of the refereed literature here, which talks about this whole thing of canine substitution, where orthodontists love to bring those eye teeth into that position. And here's out of a plastic and reconstructive surgery journal. Basically, what this says is that you're retracting the front teeth enough to literally cause the upper jaw to not grow forward. And then they have to surgically bring the upper jaw forward. So you're saving someone from 2 implants, which are simple to do and no big deal. People have them all the time. And now you're going to make someone have to have jaw surgery to have the upper jaw sectioned away from the rest of the face and surgically brought forward. And so,
you've got one profession or one specialty doing one thing and another specialty thinking a completely different thing. Why can't we have more interdisciplinary conversations?
Exactly, Mike. And this is something that anybody should understand and know. It's just common sense. So go to the next one here. Yeah, so here then is a patient that I saw who had this very thing done, and he's had the missing lateral incisor spaces closed. Now put up the next slide, Mike, and we're going to show you something, because notice his forehead is sloped way back, and we all know that that's sloped back that way because he's keeping his chin forward so he can stay alive. And you see where the black line is, where his face ought to be. But his face isn't there. So the point is, he had a stroke in his mid-50s. The point being, I believe the mere closure of those spaces for him caused this problem to occur. And so now I'll show you just how crazy that is. I'm going to show a case. Go to the next slide. And here's this patient was mine to treat. And he had this spaces closed. He had his missing lateral spaces closed. And he had mild sleep apnea, and his jaw joints are undergoing degenerative joint changes. So now we're going to show what we had to do to change all of this. This is like massive, massive treatment. Notice how his face should be where the black line is, but it isn't. It's way back. He's got facial hair to hide the fact that he has no face. So now go to the next slide, and you're going to see what we have to do to change all this for him. And we've reopened extraction spaces. We have put in teeth where the lateral incisors were missing. He now has implants. But more than that, he has undergone double jaw surgery to bring both jaws forward. And more than that, his lower jaw was trapped and held back to the point that he had condylar degeneration. And so now he has an artificial jaw joint too. So show the next slide, and you'll see him forward. He's got...
This is an example of the artificial replacement.
Yes. But, yeah. And then show his face now, though. There he is. He's had the surgery to bring him forward, and he's great. He's done with the sleep apnea. He's feeling great, happy, and life is good. But he's had to undergo all of this, and now he has an artificial jaw joint. And trust me, I do not believe that would have ever been required had he had treatment to open the small space and put in implants, and he wouldn't have had his face retracted back like this, which essentially is going to cause him to have would have caused him to die early from sleep apnea, because untreated sleep apnea is good for a 20% reduction in life expectancy. You can also go to the next slides and show a little bit more on that and show the airway improvement for him. See the airway improvement that he got?
Huge.
But we already showed you that we did the same kind of thing with orthotropics in growing kids.
Yes, exactly.
And that's what makes this so crazy, to think that you have to go through what is now probably $200,000 in American dollars of surgery to achieve this result with a total joint replacement.
Well, beyond
I don't
that,
think
Bill, you know, why
Pardon?
can't we, with simple public health messages like sit up
Yeah.
straight, keep your lips together, stand up straight, shut your mouth, you know, eat with your lips together. You know, these simple concepts from a young age should be able to even remove the need for orthotropics.
Exactly. I'd love to see it where any kind of orthodontics that has to be done would be done prior to age 6, before any permanent teeth would even come in. So you wouldn't even talk about braces in adolescence.
Yeah, you see, my grandfather was taught in a guy's hospital in London. And he was taught in, I know roughly exactly when he was taught, because he'd done 1.5 years, I think, and he joined up for the First World War, got shot up and came back. So it was right on the, you know, around the 1920s. He was taught by Harold Chapman, and Chapman said that if there wasn't space between the upper front baby incisors at 4 or 5 years for a half crown, 2 millimeters, that would be 2 millimeters in 3 separate spaces, then you were likely to have problems in the future, and they would recommend a burst of expansion. And that was standard teaching in the UK at the time.
And it was being done in the United States up until about I think into the 20s maybe. But then after that, it all went away, and it was all about adolescent treatment, which is just
the perfect smile. We call it the American smile, you see, Bill.
Yeah, and you say that without a smile on your face, because it's sadly it's true, but it's very derogatory. I mean, you look at the kids graduating high school now, and they're just not that attractive. I always say sad.
You walk into a classroom of 6-year-olds, and nearly all of them look great. They do. They look healthy, cute, good, nice facial form. You go into a classroom of 18-year-olds, it is less common. I think it's getting less and less common. And what's happening? You know, you go to the native tribes and you see these people living much more holistic, natural lifestyles, and all of them look great.
Yeah, exactly. I look at all. I'm an addicted runner, and I look at all the marathon runners, and they've all got great looking faces. And I'd love to be able to take x-rays to see how big their airways are, but I don't need to, because I know their airways are bigger and better than mine.
Particularly the 100-meter runners.
Oh, yeah.
You know, you see them lined up, all smiling. I mean, all these big, broad grins, every one of them.
So here you see this guy from the front, and you can finish up these slides and just go through them. Here's a kid that I saw years and years ago. He'd had teeth taken out by somebody else when he was 10. And here he is. He has traditional ortho done. And you can see him by the time he's done with his growth, he has no face. It's all back. And it's out of the literature. Yeah, so you can see the distance between his neck and his chin is really not great on any of those. You look at that, clear over to the right. He has no chin. And to the left, when he was 10, he had a pretty good chin. Yeah. You can just imagine what that does to his airway. And notice he doesn't have a whisker on his face. He hasn't even gone through puberty, which will make it even worse when he does. So go to the next slide, Mike, and I think we can, I like to take stuff out of the literature here, and talking about retraction causing the face to not grow. Here's another one. Appears to prevent forward growth and even cause the maxilla to grow down and back. And do the next slide. Another one, failure of the body, the mandible to grow. This is in the literature going back. It's in our refereed literature, which we seem to not really care about, or no one looks at it. And go to the next one. That's 1978. And here's yet another one. It is possible that we should re-examine the whole question of effects on posture and on respiratory function of the very act of wearing different appliances.
It's not just John Mew that's been saying this for
not
years.
At all. And this has been in our literature, but it's completely ignored.
Well, I just think that Dad shouted it loudest, and so he got the most vitriol back.
He got the most grief, exactly.
Yeah.
And finally, the next question you had for me was, the big focus on airways. Oh no, here let's go through this one here, because then I like this, because here we have a person who's had bicuspids taken out and she has sleep apnea, sleeps a couple hours a night, and she's not a happy person, as you can imagine. We reopened her extraction spaces in the upper jaw only. We were actually preparing her for surgery because we thought she was going to need it. And look at what happened in the next slide. We've opened her spaces for her on the upper only. Now, show the very next slide. And you're going to see her sleep report, which says, despite the fact that she gained 10 pounds, she no longer has sleep apnea. So here's a sleep report proving that reopening spaces only on the upper arch resulted in her getting rid of her sleep apnea. The point being, her tongue can come up and out of her throat, go to the roof of the mouth where your dad says it's supposed to be, and now we all know that. And that alone got rid of her sleep apnea for her. Now, go to the very next slide. And this is something I put together and asked this question probably 15 years ago. And I've asked this very same thing many times in lectures. And I asked people, could you retract enough to cause sleep apnea? And I've never had anyone say that you could not. Everyone, I've even had people, I have them stand up or raise their hands or whatever. So when no one does, I say, in the room, there's not one person who stood up or raised their hand. The next question I ask is, how far can you safely retract? And of course, nobody knows. And I don't know either. The obvious question there in the bottom in red is, if you don't know where safe becomes unsafe, how can you retract at all?
Also, Bill, it's the lack of informed consent. It's the lack of anyone really being told this could be a problem, particularly if you're going to do retractive type therapies, extractions, headgears.
Exactly.
You know, we should be telling people this is a possibility, and then we should be engaging in open, free, fair, full discussion about it.
Absolutely.
Meaningful engagement.
I know. In the United States, a woman sued McDonald's because she had coffee that she had. She got at a drive-in and she put it between her legs and it spilled and burned her. She sued McDonald's and won. And so now all you go to Starbucks or any of the coffee places and they have a warning on it telling you that the beverage you're about to consume is hot. Well, you know what? I don't drink iced coffee. I wouldn't buy it if it wasn't hot. And yet we ignore this, something that could have an impact on someone's health and potentially their longevity. We don't warn them about this. It's pretty insane.
It doesn't make you friends who are a professional.
No, I know that. Believe me. Finally, the next part here is there is a big focus on the airway that's really an unwelcome focus on many people in the profession. They wish it would just go away. But their knee-jerk reaction is to expand. And so let's quickly go through that. And you mentioned this previously, but let's look and see what you get for all your efforts. So go to the next slide. Here's somebody who has a 45.5 millimeter intermolar width that he gained with an appliance that lots of people use. And the fact is that's massively wider than almost anybody, way wider than my jaw. And, only people who are going to... Yes, exactly. But look at his face, and in the next picture, you're going to see his face, and his face is back, and he has no chin, and more than that, then go to the very next one, and you're going to see what his airway is. There's a study which basically says he's really close to having a very high chance of sleep apnea here, and the kid's in his late teens. I can tell you this, based on the fact that nothing gets better when you get older,
yes,
I would put any amount of money on the fact that either he has sleep apnea now or he will develop it in the future. And you can see it, his airway and cross here. We're going to show you another individual, how sad this is. Think about an 11-year-old boy who's diagnosed with sleep apnea by a camp counselor. Where was the pediatrician here? So he comes to me, it's way too late for me to do orthotropics, and all I can do is expand. So let's show these slides, and that's what you're going to see as I expand him. But his face is back just that much, and believe me, we got literally millions of kids in every industrialized country who have faces back farther than that by age 11. Now go to the next slide, and his airway is literally pitiful. That is not an airway compatible with life. Not a long life. So that's like a cocktail straw. So go to the next one, and you're going to see that I did expand him laterally, I believe. That's the in the front to back plane of space, and try to imagine breathing through that small space. That's what you're looking at. The next slide shows how we're going to expand him 10 millimeters, but he's still snoring. Upper and lower expansion, which I was taught you could never do in orthodontic training, but I've been doing it since 1985. Go to the next slide, and you're going to see that we did get some improvement in this airway, but not nearly enough. And go to the next slide then, and you're going to see more. And now we come to the front to back plane of space, and we're going to move the teeth forward. We move the upper teeth forward, we move the lower teeth forward. And I was taught that you had to take out teeth in cases like this, but I quit doing that more than 40 years ago. So go to the next slide, and you're going to see him that the mom thinks he's better off, and she doesn't see him having apneic episodes, but she's wrong. Go to the next slide, and you're going to see that he really does. And the point then with him is that he still has sleep apnea, and his only way out of this, if you go to the next couple slides, yeah, there he is. He's wearing a CPAP machine, and here he is at age 14 and a half. His face has fallen back massively because all we did was expand. We didn't correct his rest oral posture, which was horrible. His face fell back even more. Now his only way out of this is to have jaw surgery. Yeah. Sadly, I believe he has brain damage because he never really seemed that good in my office. I believe that he has serious brain damage because of this desaturation and reduced oxygen saturation. Ron Harper, PhD at UCLA, has documented all those kinds of things. And so we're really dealing with a big issue here. The next slide you come up with, show it up there. I was so frustrated. I was at a meeting in Salt Lake City in August of 2017, and that's when I came up with this. My mind didn't even, my mouth just said this: you can't expand your way out of an anterior-posterior problem, a front-to-back problem. And orthotropics I view as the solution for this, but you have to do it prior to age 10. Yes. And again, it's primarily in the front to back plane to get the face to grow forward, whereas you indicate our ancestors had that prior to the advent of agriculture and prior to the advent, certainly, of the Industrial Revolution, where we eat processed foods.
So, Bill, this next slide is related to what can dentists who are interested in this do?
Well, you know, it's interesting. In the American Dental Association in 2017, September 2017, mandated that all dentists screen for airway issues. Here we are 7 years later, and not much has changed. This organization right here, the American Academy of Physiological Medicine and Dentistry, was formed by Howie Hendon and another dentist from the New York area, probably 12 years ago, I think it is now. And our whole goal here, I'm a founding board member of this group, our whole goal is to work together because nobody can do it all. You need a physician, you need ENT, you need myofunctional therapists, you need pediatricians. And in reality, we need to go even further upstream fishing. We need to help people with their lifestyle issues. We need to get mothers counseled even before their pregnancy. And everyone needs to get on board. Rather than fighting with each other about who's going to put the braces on somebody's teeth, we need to realize we're dealing with a public health pandemic that no one's really talking about. And we need to work together and have everyone treating very, very young, long before anyone's going to say, oh, gee, I need to have braces on my teeth. We need to be, instead of treating a symptom, which is crooked teeth, we need to be treating causes, but that's what your dad has been treating for 50 years or more, whenever he got started doing it. Yeah, this then is for the
preventing. You know, we can get in young enough. We need more research in this area. We need more open debate. We need some blue sky thinking as well. And that's just what's not happening. There's groups like the AAPMD are doing really good work, but we're isolated. Is this certainly not mainstream? This should be mainstream, and why the hell not?
And that's why I think I admire you so much, because you have the attention of the world. And believe me, once you get the attention of the mothers, I call them the mama bears, what they want for their little cubs, they want the best. And they'll move mountains to get it. And they're going to travel to find someone who can do those kinds of things.
Now,
I'm semi-retired now, not seeing patients, and these
but
are
you
my
are
two men.
teaching still.
I'm teaching this and trying to, I'd love to have people from all over the world that I could refer to and say, oh, just go see somebody here and they're going to help you. I do have some people in isolated areas in the United States and one or two in foreign countries, but this is a public health thing that we need. We need tens of thousands of practitioners who understand this and are literally able to, not even tens of thousands, hundreds of thousands worldwide. That's how big a deal this really is.
But it was fascinating.
It's monstrous.
When I was training as a dentist, when I did my undergraduate dental training, which I completed in '93, sleep apnea wasn't in the syllabus. And I know that for certain because we talked about left side cardiac failure, which results in a paroxysmal nocturnal sleep apnea. So the word was used. And I remember exams, you had to prop people up at 45 degrees at night so their lungs could drain because they've got left-sided cardiac failure. Now, clearly, with the word sleep apnea was there, I knew it wasn't anywhere else. So as I qualified in '93, sleep apnea is not in the syllabus. Now, it's killing, apparently, as you say, and several other people have estimated to me, 20% of the people over 60 will die a decade early.
Yeah. It makes no sense.
Where's it come from?
That makes no sense. It's like trying to swim upstream against a tsunami, and in terms of the complexity and the amount of money that we're spending, particularly in the United States on healthcare, and all the money we spend doesn't buy anybody any health. It's completely a sick care model. And the only way to make any progress is to treat before the disease occurs. And clearly, there are books out there that are talking about this. Breath by James Nestor, Patrick McCune's books on breathing, and there are other issues that are out there. But we have to do something, and that's why I'm happy for you, because you've got the ear of the world through the internet now, and hopefully we can reach a lot of people.
I'm on my mission to find answers. Now, finally, Bill, I want to see if you're a parent and you hear of this lecture or you've heard about airway-friendly orthodontics, where should they go? Because I'm concerned that there are a lot of people who, well, it's a very easy thing to say, I'm an airway-friendly orthodontist, and be treating exactly the same way as you've always treated. How do you know that you're going to find a good practitioner? Because it seems that everyone I talk to now is jumping on the airway bandwagon.
Mike, you're absolutely right. And there's no credentialing at all. And many people they're just jumping on to do their little thing. And what they don't understand is that most of what we do in orthodontics is retractive in nature. And the face is going to grow down and back. And so often someone would be better off if they never had anything done at all, honestly, than what so often is done. The few people who don't retract, they're very few and far between. So I guess what you have to do is ask the practitioner, so show me your cases, show me how, let's look at the airways. So show me a case where you have dramatically improved the airway, and how did you do this and why did you do it? And let's look at the long-term follow-up, and let's look at a sleep study to prove that there's something really here, that you've gotten some real results.
And of course, parents could go and look at members of the AAP&D, and they could also look at people who've been on your programs. We've put links below. Right. We've been showing some links of these as we've been going through.
That's the best way. And I sadly do have people that I can refer to, but in most localities I do not.
Yeah.
And that's why I'm still at this, because I don't want to take what I've learned from your dad and other people. I don't want to take that information to the grave with me. I think we have such a problem to address here.
Okay.
Monstrous public health issue.
Thank you very much. And that's been fantastic. Really, it is as informative as ever. It's great. And thank you very much. You have, in my mind, you were the father of this whole airway orthodontic that we now have. Listen, it was a pleasure. Thank you much. We will get you on again, I know, soon.
Okay, very good. Very good. I'm glad we got this done, Mike. Thanks, Bill. Thanks to both of you.
That's okay.
Bye now.
Take care. Bye.